Hello and welcome to January 2023's edition of Trachea Talk. This is our podcast where we review the literature that's caught my eye in the world of tracheostomy care in this past month. As ever, on the website there's some accompanying resources which will take you through a deeper dive of the papers, and there's links to the full text of them if you want to have a look for yourself. In this episode we've got a couple of papers focusing on patient assessment, prognosis and the management of long-term critical illness. I'm going to dive straight in with the first paper, which is from the Capital Medical University in Beijing. This is published in the European Journal of Physical and Rehab Medicine, and they were looking particularly at secretion retention as a predictor of decannulation. And the population they were looking at were patients who had severe brain injury with tracheostomy. They looked with FEES, which is fibre optic endoscopic evaluation of swallow, camera up the nose, looking at the back of your throat as you manage secretions and sometimes as you are challenged with liquid or more solid food. There's something called the Murray Secretion Scale, which is a scale which goes from 0, which is normal management of secretions, up to 3, which is consistent pooling of secretions that you're not able to swallow and clear out of the way. So while I've been talking and while you've been listening, we've all probably swallowed a couple of times without thinking about it, because the secretions we produce in our mouth as part of normal saliva production like that have to get swallowed out of the way. And if you have a problem with either your swallowing mechanism or your brain trying to control that swallowing mechanism, then the secretions can build up and can start to cause problems. If you have lots of secretions, that's one of the factors that may mean that you can't have your tracheostomy removed. And so what this group did was took a group of patients, 121 patients in fact, who had severe brain injury and a tracheostomy, and they used the Murray score based on their FEES to work out whether the function of the pharynx and the ability to manage secretions was a good predictor of decannulation. So what they found, that if you had the worst type of secretion retention, so the Murray score of 3, it was an independent predictor of prolonged tracheostomy. There were very, very wide confidence intervals here though. So they had an odds ratio of 65, which means that you're 65 times more likely to require a long-term tracheostomy at that level. But the confidence interval went from 6 all the way up to 650. So that tells you that although it's statistically significant, that there's a huge range there. But nonetheless, it's quite interesting to look at this Murray score and certainly the worst score as a predictor of whether you're going to need a tracheostomy for long term or not. Now, 84 of those 121 patients, so nearly 70%, were successfully decannulated during their hospital stay. So these are a patient group that were proactively managed, and the vast majority of them improved to the point where they could be decannulated. But what they found was that if you have problems with your secretion management, then that was a real predictor of the requirement for long-term tracheostomy. They also found that a low conscious level and decreased laryngeal sensitivity, laryngeal sensation, were also significantly associated with prolonged tracheostomy. But, they did get lots of these patients decannulated. So the authors conclude that secretion retention is a robust and objective clinical sign which can be helpful in predicting who's going to need long-term tracheostomy. As I said, there are other factors associated with this, and having a low conscious level and poor laryngeal sensation are probably all tied in with the finding that you have lots of secretions. So there's probably a little bit more to unpack here, but nonetheless, a useful study showing how FEES can really help to determine what the best course of action is for patients with tracheostomies. The next paper comes from my place, so Wythenshawe Hospital in South Manchester, featuring my speech and language therapy colleagues led by Professor Sarah Wallace. So this study looked at FEES again, but we were using it to look at laryngeal abnormalities in patients who'd recovered in the COVID-19 pandemic. Patients who'd been placed on prolonged mechanical ventilation, many of which had had tracheostomies. So there were 16 patients in our first wave that we used FEES for. Now, it's worth saying we normally use FEES a lot more than that, but at the start of the pandemic, you may remember that there was a lot of anxiety around aerosols and exposing staff to airways, and fees at one point was extremely limited. But from these 16 patients that we assessed by fees who'd had prolonged tracheal intubation and tracheostomy, we identified at least one laryngeal pathology with a median of 3 abnormalities per patient, which is quite a lot. So 63% of those patients had one clinically significant structural pathology, and that the most common pathologies were edema in about 3/4 of the patients, abnormal movement of the vocal cords, and then atypical lesions. And by atypical lesions, it was typically granulomas or ulceration, usually sitting around the vocal cords. Fees was useful in identifying silent aspiration, so patients who looked like they were managing to eat and drink but were aspirating. And fees prompted a change in management for nearly all of those patients, guiding interventions such as targeted dysphagia therapy and ENT referral. So certainly the message yet again is that patients who required prolonged mechanical ventilation often have occult laryngeal pathology, and fees for any patient who ends up requiring a tracheostomy is a really useful way of assessing laryngeal and pharyngeal function, for guiding therapies, for example, directed at secretion management, for thinking about the timing or prospects of decannulation, as in the previous paper. But we certainly found in the COVID-19 subset, the incidence of laryngeal pathology was an awful lot higher than our non-COVID cohort. So, 2 messages. Fees is a crucial tool, and as part of the multidisciplinary team led by our speech and language therapy colleagues, you can find all sorts of things that will help guide safe weaning and swallowing rehab. But there's a COVID-specific element here too as well. So COVID-19 is obviously an upper respiratory tract virus which causes airway inflammation. We compound that by sticking a tube down the airway and possibly a tracheostomy. And so, not surprisingly, you get more upper airway problems in this COVID-specific cohort. So I hope you find that useful. Our third paper this time comes from Germany, published in Science Reports by Blasius and colleagues. The objective here was taking a multi-centre retrospective study aiming to develop and validate a new scoring system. They call this the Tracheostomy in Thoracic Trauma Prediction Score, or T3P for short. And what this group did was they looked at the likelihood of tracheostomy in multiply injured patients with severe thoracic trauma. Now, there's various scoring systems to describe how severely injured you are after trauma, and they use something called the AIS thorax score. And this is a tool which is used to classify the severity of chest injuries. There's other areas of the body which have similar AIS scores, but the scores range from 0, so no injury, through to 6, which is an unsurvivable injury. Higher scores mean more trauma, which usually indicate a greater risk of complications, longer ICU stays, and a chance of higher mortality. So, for example, an AIS thorax score of 5 or 6 represents critical thoracic trauma that requires immediate intervention, which may be complex and almost certainly involves critical care. So they looked at data on patients aged 18 years or older who admitted to one of 6 participating academic level 1 trauma centres, and patients had multiple injuries, but they looked at the AIS thorax scores greater than 3, and they looked in a 4-year period between 2010 and 2014. They included just over 1,000 trauma patients. They found that independent risk factors for requiring a tracheostomy were if you were intubated pre-hospital, so this is by the paramedics or people outside of hospital having to intubate and ventilate patients because of their severity of injury, a diagnosis of pneumonia while you're on a ventilator, and longer duration of mechanical ventilation, which of course may well be linked to a diagnosis of pneumonia. They also found that severe head injury independently predicted tracheostomy, which arguably is obviously an entirely separate topic, but tied in with patients who are multiply injured with an AIS thorax score of over 3. If you had an AIS head score of over 3, then that was an independent risk factor for requirement for tracheostomy. The severity of thoracic trauma itself did not actually predict the need for tracheostomy, but they felt that their validated score that they put together had a high predictive validity, where they added in these different factors of pre-hospital intubation, pneumonia, duration of ventilation, and then the brain injuries. But it had a pretty high specificity, so 0.96, and the score performed reasonably well, sensitivity of 0.68. So interestingly, patients with sepsis actually had a lower risk of tracheostomy, and the author said this finding warrants a bit further investigation to clarify what they call causality, which is, look, why would you have a lower risk of tracheostomy if you had sepsis? Which made me just wonder a little bit about the quality of the data set and the variables in there, because you'd imagine if people have sepsis, that's a longer course in intensive care, they're sicker patients, and sort of ties in with the pneumonia really. So I was surprised that wasn't associated with an increasing risk of tracheostomy. But the overall point is that they've looked at the data set, they've put together a score which is a potential tool for the early and objective identification of patients with severe chest injuries who may need a tracheostomy. And I think the authors reasonably conclude that this could help clinical teams making early decisions about optimal care, where you're going to target your resources. And there are some potential benefits to an early tracheostomy, which I think if the score supports early tracheostomy, that may be something to benefit these particular subset of injured patients. So that's it for this episode. Thanks for listening to the end. We'd welcome any comments on our social media platforms, and we'll do our best as ever to respond to them. You can find lots more information about tracheostomy care on our website, which is tracheostomy.org.uk, including more podcasts, more videos, more information about how to get involved in some of our work. Please note that the comments that you hear are our own comments and do not necessarily reflect those of all the different organisations for which we work. Look forward to seeing you again next time. Bye for now.